Hello and welcome to our webinar today. My name is Dr. Mary Cowan. I will be facilitating the webinar today as well as transitioning our speakers as we go along. And so today we're going to address the topic of radiopharmaceutical extravasations. And this is particularly in nuclear medicine. So since nuclear medicine touches the lives of so many people living with chronic or life-threatening illnesses, we want to take a minute, we want to create awareness on this topic. So rather than just producing a simple image of anatomy, nuclear medicine goes one step beyond, and it really provides a functional and anatomical information. So this afternoon, we're going to discuss that radiopharmaceutical extravasations. So extravasations happen when the radiopharmaceutical is accidentally injected into the patient's arm tissue instead of completely into the vein. So our learning objectives were indicated in the webinar, but our high-level goal today is really to create awareness and to learn as much as we can in this 90-minute session. What we want to do first is get a feel for who our audience is so we can help tailor our presentations to you along the way. So I'm going to ask Ted to pull up our first polling question, and it's going to just have you ask how knowledgeable you are about the subject matter. Do you consider yourself a subject matter? Feel you're sufficiently informed? Maybe you would like to get more information regarding the subject, or possibly we would welcome you that if you have a limited knowledge base of this. So while you're answering that poll, I just want to give you a brief background. I am a trained radiologic technologist. I'm also a trained educator. So I was really interested in this topic, and I did have the chance to speak with a lot of the panelists this week about their topics, and it just really resonated. And I just heard over and over again about how they really want to create a knowledge and awareness of this. So that's really what piqued my interest about this, and I learned along the way. I am, in full transparency, I had a lot of questions along the way, so I'm really excited for everyone else to learn and gain the subject matter that I did about this topic. So we'll just have you keep thinking about that. And so again, based on who our subject matter, what we find here today, we'll go ahead and try to tailor our questions and our presentations the best we can to that. So we'll just let you kind of come in on that poll. And we will have time for questions and an opportunity. We will address those at the very end of the presentation. As always, if we're going along with information and you want to put it in the chat box so that we're made aware of it, or you want to keep those thoughts together for it, you're sure welcome to do that throughout the presentation. But we will address all of those at the end of the presentation. But we look forward to any feedback you have throughout the presentation in that chat box. So Ted, can we go ahead and close that polling question and we'll see our results? Okay, well, that's smart. So we have a kind of a split audience on, so 4% are subject matters. That's great because our goal here really is awareness. About 23% feel informed, and half of our audience wants to gain more information, and that's really why we're here today. So that's a really great thing for us to take a hold of. I want to go ahead and introduce our first panelist today. We are fortunate enough to have with us today Pam Cole. She is a patient advocate in metastatic breast cancer thriver. And so she's going to give us a really great patient perspective first on just how this works from a patient perspective. So Pam, we want to welcome you today. I'll go ahead and have you pop in on us and we can visit with you about your perspective and about your information that you have for us. So as I said, I do not see your webcam. So if you can pop your webcam up for us, we can hear you, but we can't see you.
Well, I'm trying.
Sounds good. So while Pam does that, Pam knows CT and PET CT. She had an early and proper diagnosis thanks to this. So Pam, we can see you and hear you. Okay. So right. If you want to go ahead and share your perspective, we would love to hear that from you.
Thanks, Mary, and sorry about that, but
no problem.
I'm Pam Cole, and I have been a cancer patient for 13 years, and I am so happy to be here today to talk about why nuclear medicine and radiopharmaceutical extravasations matter to patients. And since I'm kicking this off today, I have been strongly encouraged to read my remarks so that I stay on time, so bear with me. I was diagnosed with stage 1 breast cancer with a very low risk of recurrence in 2009. I proceeded with my treatment, and after 5 years, I was declared cured from breast cancer. And my family and myself did lots of happy dances, obviously. But 3 years later, the breast cancer came back. My doctors kept saying it was just a recurrence and they would treat it again. But I've worked with the Komen Breast Cancer Foundation for several years. So the good news is I know a lot, and the bad news is I know a lot. And I kept asking for a PET scan to make sure that it really was just a recurrence. And finally, after 2 months, I had the PET scan and discovered that my just a recurrence was actually stage 4 metastatic breast cancer, or MBC as we call it. 2 small metastatic tumors near my lung. I've been on treatment now for MBC for 4.5 years and will be in treatment for the rest of my life. PET scans and bone scans have become a big, big part of my life. PET scans, it is these scans that discovered my early MBC when I had only 2 small tumors. I had had no symptoms. There was no reason for me to be worried about a recurrence, and certainly no reason to be worried about metastatic disease. I had been declared cured. And even with the recurrence, my doctors were not concerned. But I have no doubt that if I had not had that PET scan, my MBC would have been diagnosed much, much later. And instead of 2 small tumors, it probably would have been 10 or 20 tumors spread throughout my body, making it so much harder to treat. Now, I totally understand that I have an incurable disease, that PET scans and bone scans are not going to save my life. But on any given day, it will help save the life of other patients. And because of the early scan and the scans that I have every 3 months for the past 4 years, my disease has remained relatively stable. These scans inform our treatment decisions. These scans tell us if the treatment is working. And these scans matter to the length of my life and certainly to the quality of my life. These scans need to be accurate, and these scans need to be safe. In the MBC community, we talk a lot about what we call scanxiety, that gnawing fear and anxiety we start to feel about a week before our scans. We're worrying about progression. And progression, that fear is real, and it just is. The last thing we need is to also be worrying about whether the scans are safe and if they are accurate. I need to know if the radiopharmaceutical has infiltrated into my tissue, and my doctors and I need to know if I've received the correct dosage. And if the scans aren't telling the whole story, then we're likely to make the wrong decision about my treatment. This webinar is so important because we as patients and our medical teams need to understand that radiopharmaceutical extravasations are an issue. Efforts can and should be made to make this a preventable error go away. Patients and their physicians need to know that their procedures are done as accurately as possible so that they know that their patients are getting the best treatment. And patients need transparency. Patients need to know which centers are doing these injections well and which are not. And patients need to see evidence that our injections went well. This will provide us the peace of mind that we need to know that our medical procedure is helping our care. And really, most importantly, this is a solvable problem. Medical facilities, by knowing and documenting these incidences, can retrain staff, and they can implement quality improvement programs. Folks, this is a problem that can be solved. I'm so happy to be participating in this webinar. There are some real experts coming up next. They're going to talk about how extravagations impact images, how they affect the tissue, and how they can be mitigated and prevented. I'll stick around, and I'm happy to answer any questions later during the discussions. Thank you so much, and I'm looking forward to a very informative session.
Thank you so much, Pam. I think it's crucial for us to understand a patient perspective and really the why behind all of this. So you give a really great indicator from a patient perspective on the why. So thank you for sharing your story today and for scripting that. I know that must have been an incredible amount of work. So thank you for putting the time and effort in it to help changing other people's lives. We really appreciate it, and we're so grateful to have you here today. Thank you.
Thank you.
I'm going to go ahead and let Ted bring up our second polling question so we can get a feel for, and then Pam, I'll let you go ahead and you can mute and hop off your webcam, and we'll bring up that polling question, our second polling question. And we want to get a little bit of an idea about what your level of concern is on this topic. So is there no concern? Is there may be a concern in terms of image quality and patient care? Do you feel it's a neutral incident? Maybe you're not one way or the other. And then also, if you're just unfamiliar with the topic or you're not comfortable answering from the perspective, you're sure welcome to do that as well. So we're going to leave this open for about 30 seconds. So if you want to hop on and answer this question, then we'll give you a short window here so we can keep moving and we make sure that we get to all the panelists today. So again, if you have any questions or comments about like why we're going along, you're sure welcome to submit those. And like I said, we're happy to answer questions at the end, and we hope that this information is really important and you can gain more subject matter. I know, like I said, I've had a really great time this week meeting these subject matter experts and learning about them and learning about the area. So Ted, I'm gonna let you go ahead and close that poll so we can keep moving forward here. So again, 72% thinks that it is a concern in terms of image quality and patient care. So again, thank you so much for your feedback. We really want you to interact with us throughout this. So thank you for taking the time to do our polls. I'm going to go ahead and introduce our next speaker here. This is Dr. Townsend. He is an IEE fellow and the co-inventor of the PET-CT scanner, and I'll ask him to bring up his webinar and webcam and presentation while I'm finishing this introduction here. I have to admit, I'm a little bit celebrity awestruck doing this with you. I was like, wow, this is great. So it's so great to have, you know, people who really have taken the time. You're considered a leading authority in the hybrid imaging systems, as well as the pioneer of the three-dimensional PET and reconstruction algorithms. So I'll let you go ahead and start your presentation, and we will love to hear from you.
Okay, well, I hope you can see the screen, and it's a great pleasure to be here, and thank you for that kind introduction, Mary.
Everything looks great on our end, so you're spot on. Okay,
cool. All right, so my topic today is the effect of extravasations on image quality and quantitation. And I'm going to cover three aspects of this. First of all, I'm going to give you a very simple explanation of radionuclides for medical imaging, how they work and how we use them for imaging. And then I'll talk about the effect of extravasation on image quality. So my focus will be more on the physics of the imaging and the effects of extravasation on that image quality. And I'll also spend a few minutes talking about image quantification, because we're interested not only with making diagnostic quality images, but also in extracting quantitative information from those images. And then I'll finish with a little summary of the points I want to make. So first of all, radionuclides have been used for medical imaging for many years, back in the 50s, and it was a technique that was invented by George de Hevesy, a Hungarian chemist who received the Nobel Prize for his proposal in 1943 for the development of what's called the tracer technique, because what we're using is a tracer to determine the function of various organs. How do we do this? Well, first of all, we need what's called a carrier molecule. And the one that I'm just going to take as an example is one that targets one organ. We can target organs, we can target pathologies within the body. But just to make it simple, let's assume we have some molecule that is targeting the liver. Obviously, if we inject that molecule, we're not going to know that it goes to the liver because we can't see directly the effects of where that molecule goes. So the principle of tracer imaging is to label that molecule with a radioactive nuclide. The advantages of doing that is that the carrier molecule will take the radionuclide into the organ of the target organ, the liver, and then as that radionuclide decays, we can position the detector outside the human body and detect those decays. And since they're coming from the liver, we can, in principle, make an image of the liver using this technique. So the radiochemistry process is to combine a radioactive nuclide with a carrier molecule. And we then prepare a syringe of this solution, what's called a radio-labeled carrier. And the procedure is to inject this into the patient intravenously. And that's what we'll be talking about today, the issues when something goes wrong with that injection process. If it works successfully, then we have a very clean injection. You can see the peak. It's carried through the circulation into the liver. And in this simple example, you can see that the yellow carrier molecule has now been absorbed within the liver and has taken the radioactive nuclide into the liver with it. The imaging process involves positioning a detector outside the patient, and then as each of the radionuclide molecules decays and emits some sort of gamma ray or photon, this is detected by the detector and makes an image of the liver. And then this is passed on to the physician, and you'll hear about that in the next talk, a physician who will review that image and assess the quality of the function of the patient's liver. Now, interestingly, if we were to look at the, if we were to look at the quality control of this procedure, what we find is that the production of the radioactive nuclide in the cyclotron is highly controlled and has very high-level quality control procedures, as is the production of the radionuclide, labeled radionuclide in the syringe. This is all part then of the radiochemistry procedure, which is subject to very strict quality control and quality assurance procedures. The imaging is also very strictly controlled. The camera is, the functionality of the camera is checked every day, and the imaging procedure is carefully controlled. And of course, the imaging review is also controlled according to the set procedures that physicians use to read and interpret the images. But curiously, what is not so strictly controlled is the injection of the radioactive carrier into the intravenously into the patient, and that's what's shown here in number 2. Now, what happens if the injection of the radio-labeled carrier into the patient is not carried out cleanly, is extravasated, for example? Well, first of all, if there's no extravasation, you get a very clean bolus injection of the radio-labeled carrier, resulting in a typical image. That's a PET image using fluorodeoxyglucose, where glucose is the carrier and fluorine 18 is the radionuclide. You get a high quality image, high contrast, showing high contrast internal organs. The radio-labeled carrier is extracted from the blood, so you get low activity in the blood pool. The image, as you can see, has very high dynamic range. There is no radiation dose at the injection site, since it was a clean injection. And the overall whole body dose to the patient is extremely low, since the injected radioactivity is low and it's distributed uniformly throughout the patient. If there is some extravasation, and the curve shown on the left-hand side shows something like 20% extravasation, which then slowly resolves as the radioactivity left at the injection site is absorbed into the blood and then distributed through the body. But obviously, the fact that it was not cleanly injected reduces the overall image quality, reduces the contrast of the image, as you can see in the image in the center, decreases the activity in the blood pool, and reduces the overall dynamic range. And of course, you'll get some radiation dose at the injection site in a relatively small volume of tissue. And then finally, when the extravasation is severe, maybe up to 100%, so the entire dose is left at the injection site and then slowly leaks into the circulation, you'll have very poor image quality, low internal organ contrast, high residual blood pool activity, poor dynamic range, and of course the high activity at the injection site can result in streak artifacts from the process of reconstruction, and also potentially a high radiation dose at the injection site, since it's not distributed throughout the body and is only slowly absorbed into the circulation. Now, what is
Dr. Townsend, I'm going to jump in here real quick. I want to make sure that we have time for how it affects image quality and image quantification, and we have about 3 minutes left.
Okay.
So I want to make sure we get to both of those factors.
Okay, so I've got 2 slides on that. Image quality, as you can see on the left-hand side, as the dose, the extravasation of the dose, as it increases, the image quality is reduced. So if you look at that little tumor in red, you can see that as the extravasation increases, it's harder and harder to determine the position. In fact, it's harder and harder to determine that there's a pathology there. Now, one point that's often been made is that the extravasation can be seen because it's within the imaging field of view. This is true if you're imaging the brain or the head and neck area, as shown in the central image, and the box in green shows the imaging area, which is performed with the arms down. However, if you're imaging the rest of the body, frequently the image is acquired with the arms up, and that's the image on the right-hand side. And since the upper part of the body and brain is not imaged, you would not know that the dose is extravasated in the arm, as shown there on the right-hand side. And then the final point is what happens to the quantification. One of the quantification measures that we extract from the image is called the standard uptake value. And the formula is shown there. It's the activity in that little region of interest divided by the injected dose and the patient weight. And obviously, if the injected dose is not cleanly injected into the patient, the actual dose circulating will not be the dose in the syringe originally. And that will affect not only the SUV, the standard uptake value, but also the metabolic tumor volume, which includes an SUV, and the total lesion glycolysis, another quantitative value extracted from the image that also includes the SUV. And so what happens during the uptake, if the injection is not extravasated, the uptake is very clean, and you can see the SUV reaches a certain value at the imaging time. If the dose is extravasated, it is likely that the SUV will be incorrect at the imaging time as extracted from the image, and the interpretation of the image could be compromised for the physician. So in summary, nuclear medicine is a powerful technique for diagnosing, staging, therapy monitoring, and treatment of disease. The bolus injection of a radiopharmaceutical into the vein is a critical step in the imaging process. Extravasation of the dose potentially results in reduced image quality, inaccurate quantitation of image metrics, and poor use of the injected radioactivity. And while such procedures results in very low radiation exposure to the patient overall, extravasation may lead to significant local exposure at the injection site, and of course less activity then for the imaging process. So the injection of radiopharmaceutical is one step in the entire image process that is currently not subjected to a rigorous quality control procedure. Thank you.
Thank you so much. We really appreciate your insight, and it gives us an idea of all the different effects on that. So I'm going to let Dr. Kaiser bring up his presentation and share his screen while I go ahead and give you a brief introduction. So now we get to hear from that physician application. So Dr. Kaiser is a nuclear medicine physician and medical director of molecular imaging. He has spent the last 4 years studying nuclear medicine extravasations at 3 different centers, and has published research, case studies, and quality improvement projects related to this subject matter. So Dr. Kaiser, your screen is up and sharing. It looks great. I will let you go ahead and take it away.
All righty. Thank you very much. So we're going to start from the beginning instead of the end. I think that works a little bit better. So what I'm going to talk about is what happens when these extravasations happen and how it impacts the clinical read and interpretation of the images. And so, as Dr. Townsend told you, nuclear medicine kind of stands apart from other type of radiologic modalities. So the way we get our pictures is a little bit different, and what it does is a little bit different. So unlike CT or X-ray, which kind of tends to be more on the anatomic imaging piece, we're actually imaging the physiology of organs and imaging cancer function and viability with what we're doing. So that does set us apart from other type of imaging modalities. And the other thing is those types of modalities like CT and X-ray make their images by shooting X-rays or photons through a patient from the outside. What we're doing is putting a radioactive material inside the patient so that the images will be generated. The photons emit from the patient and hit a detector, thus creating the images. So what I'm showing you here, I'm not sure if my cursor will appear or not, but these are several like real cases that we have had happen here where there was an extravasation of the radio tracer. And as you can see,
it does appear, so you're welcome to use it. We can see it just fine.
Okay, fantastic. So as you can see on this first image over here on the left, there was a very severe infiltration. This patient had his arms up, and we were able to see the infiltration, but you can see how it affected imaging to the brain. And we do actually review images of the brain completely, and this image would have been very disrupted. All these other ones kind of show a similar appearance. You can see kind of a less severe infiltration here. Here's one where the patient was imaged with the arm down. And you can see how it's impacting imaging to the liver here. He was being evaluated for a cancer here in his chest. And all of these other ones are very similar. So these are all PET images that have extravasation, and the image quality is degraded. You can see how washed out this image is, despite what appears to be a very tiny infiltration. Is something that we'll talk about here, because just the appearance alone does not necessarily tell you how severe the infiltration is. This is actually a bone scan patient. So when we talk about PET and nuclear, we actually combine the 2 modalities under one umbrella. It's called molecular imaging. So we also would include nuclear amongst the PET imaging. And this is a bone scan. So normally you'd be able to see each individual rib had the injection been adequate, but you can barely make out the ribs in this patient, and the vertebral bodies are very poorly delineated. So this was a very bad example of an infiltration impacting the image quality. So why is this a big deal, and why do people not know about this? Well, there's several reasons why people are not attuned to this. For one thing, on the technologist side, the doses that we give are given in a very small volume, typically on the order of like 1.5 to 2 cc's. So when you infiltrate this type of volume, you're not necessarily going to see it clinically. Think about if you're injecting contrast for a CAT scan, that's given through a power injector, and it's a lot higher volume, 90 cc's, for instance. And you're going to see a big swelling or redness, or the patient will know something's going on. Also, with these very small volumes, you're not really able to detect it visually as you're injecting it, and there's no swelling because of such a small volume. These patients very rarely complain of pain with these small volume injections, and so they don't know anything has happened. So without patient discomfort, you just assume everything went fine. So these are some things that impact the technology side. On the physician side, you may not know there was an infiltration because as we have seen previously, the injection site may not be in the field of view. Many times these patients will be scanned with their arms up, and it'll be possibly a hand vein or a forearm vein, and it won't be included in the imaging, so the physician won't know that it's happened. So if the image quality is compromised, you really don't know why it happened, because you just work on the assumption that the infiltration, that there was no infiltration, that the dose got into where it was supposed to go. So we use these procedures, nuclear medicine and PET, for various things. So as we've already seen, it's very important for oncologic staging and treatment assessment. As we've heard by our first speaker, we use this for almost all types of cancer, PET and bone scan. Almost every cancer will be staged or restaged in this method. And when we do this, particularly with PET, we do quantitative measurements. As Dr. Townsend mentioned, we do an SUV measurement for a baseline study. And then any follow-up, we use the SUV measurements to kind of determine, was there a favorable response, or is there progressive disease, or was there a complete response? So we are able to make those determinations. We also do cardiac imaging, both PET and with nuclear imaging. This is not so much a problem with PET imaging because the isotopes that we use are very short-lived, and we don't have to kind of stagger the doses. But when we're doing SPECT imaging as a one-day exam, many times we have to give a low dose for rest and a high dose for stress. So if you give your low dose of, say, 7 millicuries, and you take your pictures, and then you go to do your stress images, and you think you injected 21 millicuries to get over any residual activity in the heart left at rest, then you're making an assumption, not knowing that there was an infiltration, where you may have only injected 7 millicuries into the patient. And that way, if there is any type of blockages in the heart, you would not be able to detect it because you are not able to get activity above what you were given at rest. We also do these PET assessments mostly for neurologic disease, where we have some quantitative things that we do for Alzheimer's type imaging. And we also have quantitative evaluation for when we're doing seizure localization. So any procedure where we may have quantification, we could have an impact to the patient management. So I'm going to give you a couple of examples of this. This is a real patient that we had occur here many years ago when we first started doing this, and we were just starting to really pay attention to these extravasations. So this patient was being staged for a lung cancer. As you can see, this uptake in the left lung was the lesion that they were looking at, and they're trying to see if he had disease elsewhere. Well, he had a very severe extravasation, as you can see in his right antecubital fossa here, and it caused a streak artifact through the liver area in the upper abdomen. So this patient was originally staged as a T4N0M0, which means that there are no lymph node metastases and there are no distant metastases. So this patient was actually a surgical candidate based on the scan, but because we didn't like the way the streak artifact occurred through the liver, and we thought this was going to degrade the images, we went ahead and repeated, had him come back 3 days later and repeated the scan. Well, what happened was we did an SUV measurement on this tumor, and it almost tripled when we got to here. So the quantitation was very much off because we made the assumption that all of the dose that was given to the patient had been distributed evenly throughout the body, and it actually impacts the SUV, as you saw the formula that Dr. Townsend showed. When we did this repeat, we actually saw this little dot here. That's actually an adrenal metastasis that was not recognized on the first scan. So this patient actually had his complete management changed and got restaged because now we have what we call T4N0M1 disease. He had an actual distant metastatic focus that was not appreciated initially. And so from that point on, he was no longer a surgical candidate. We based our management on this here, he would have gotten a big surgery, a long recovery, a lot of cost, and then come to find out later he had a metastasis down here. That would not be very good. So at this point, the patient was relegated to chemotherapy and radiation.
Dr. Kaiser, I'm going to jump in here because you have about 2 minutes left, just under about 2 minutes, and I really appreciated your last slide about the considerations for patient and like pros and cons. So if you want to keep that in mind, you have about 2 minutes left with us.
Okay. So this is just one other example. I'll just show you real quickly, but this is a patient that we actually have some SUV measurements on. This is a patient that had, I believe, a lung cancer, was found to have a new adrenal mass. When we did these measurements, and you can look for yourself at the numbers, how everything changed from day 0 to day 7 with the infiltration and without the infiltration. So the numbers are very impactful, and this is something that really would have changed, follow-up imaging. As we've heard previously, if you don't have accurate data, then you can't really, manage patients correctly. You'll mismanage them. You may think the disease is progressing when it's not, or maybe getting better when it's not. So it's very incumbent upon us to be cognizant of these infiltrations when they occur, because they do impact patient management as well as image quality. So just in closing here, there are what we do here at Carillion is when we have these severe infiltrations that I've already demonstrated, we will have the patient come back for repeat imaging. We do not recharge the patient. We credit out their initial study, and we will bill out the second study, but they will not be charged for any of that. The inconvenience to the patient is present, though. They will have to come back for this exam as a repeat, and many of our patients have to drive some distance. There is additional radiation exposure. There's added cost, basically in the form of an extra dose and staff cost. So when this occurs, though, whenever we have an extravasation, we will tell the patient about it and offer them a chance to come back for free imaging or for a repeat scan at no additional charge, because we want the data to be right. And the patients are very appreciative of this. So just to close, we didn't even mention radiotherapeutics, but this is a whole other issue to consider, because these are alpha and beta emitters, which can cause severe damage to tissue if extravasated. And this is a very rapidly growing field for treating cancer. And if this were to occur, you could have some serious problems. So with that, I will go ahead and close with that.
Thank you. And it's great. I love the progression of knowledge base that we have here, from a patient to a subject matter expert to a physician. So we really appreciate your insight, and it's great to have every side of this. So thank you so much for taking the time with us, Dr. Kaiser. Okay. I'm going to have Dr. Fisher, if you want to start bringing up your webcam presentation and mic. And also, while we're doing that, we're going to pop up a third polling question here while Dr. Fisher gets his presentation up. Ted, if you want to pop up that third polling question, we'll address that quickly. So the poll will be open here. In terms of, we're getting a basis for the energy emissions from decay is routinely used diagnostic radiopharmaceuticals. Do you believe they're solely gamma emissions leaving the body? Are solely gamma emissions resulting from other processes? Include gamma emissions leaving the body and others? Or none of them may be in your scope of knowledge. So Dr. Fisher is a medical physicist, internal dosimetry specialist, and radiation safety professional, a past president of the Health Physics Society and past member of the Nuclear Regulatory Commission's Advisory Committee on the Medical Uses of Isotopes. He is currently on the faculty of Washington State University and the University of Washington. So Ted, I'll let you close that poll up, and we'll welcome Dr. Fisher.
Thank you, Dr. Cowan. My talk addresses the clinical significance of radiopharmaceutical extravasation in terms of physical radiation dose imparted to two different tissues. First of all, the infiltrated tissue, and secondly, the adjacent skin, namely in that skin, the most sensitive layers of the skin, which are the basal cells. Okay. This is to assess severity, and to do that, we need to calculate radiation dose. To calculate radiation dose, measurements are required to characterize the behavior of the material over the course of the event. Many persons assume that diagnostic pharmaceuticals cannot impart sufficient energy to local tissues to be of concern. However, we see that that is not necessarily the case. And I'm going to fix something here.
It's okay.
So what exactly is radiation dose? It's the amount of radiation energy imparted per unit mass of affected tissue. The biological effects of dose have been well characterized for many different endpoints as indicators of tissue damage, as illustrated in this dose response curve or set of curves. In this example, the surviving fraction of irradiated cells is different for different types of endpoints.
And Dr. Fisher, the slide represents basically the known, what we know about this, correct? So I know often in radiobiology, we like to have a known. So this slide represents things that have already been studied, and you can say with certainty, this is how that happens, correct?
Yeah, the point being that dose correlates with severity of effect.
Okay, sounds great.
Those
Thank you.
severities vary from one tissue type to another.
Yep, okay.
So radiation dose is calculated by considering all of the important factors constituting determinants of energy imparted per unit mass of tissue. These determinants include the radionuclide characteristics, the infiltrated tissue mass and geometry, the activity that is measured in terms of disintegrations per second or in terms of fraction of total administered activity residing at the site.
Dr. Fisher, you gave a really great example. When you and I talked earlier this week, you gave a really great example on the geometry and the shape. Can you share that example? We talked about that pancake shape and the pencil and the tennis ball. I just thought I got a lot out of that analogy. Would you be willing to share that?
Yeah, the geometry can vary, and if we think of a pancake shape, the dose is going to be much different to that pancake than it would be to a tennis ball type of infiltration, because in the tennis ball case, a lot more of the energy is absorbed locally, whereas a pencil-like distribution or a pancake, a good part of that radiation energy will leave the site, either to surrounding tissue or to the infinite space beyond.
Okay.
It's
Thank
really
you.
important. You bet. It's really important to measure the retention and clearance biokinetics at the site because they vary for different radiopharmaceuticals. And in consideration of the radionuclide, every different radionuclide used in medicine has its unique emission types. And those energy factors are very different from one to another. We also have to consider the fraction of energy absorbed for each emission type locally at the site to calculate dose and take into account any decaying chain progeny. This is important, that the decaying chain progeny are mostly important for the alpha emitters such as radium-223.
Okay, can you explain the decay chain progeny? You and I had talked about it kind of in terms of a family. Can you kind of share how you explain that to me? Because you did a really great job explaining it to me, because I didn't quite know. I couldn't have defined decay chain progeny before I talked to you.
So for the case of radium-223, the parent, which is radium-223, decays to another radioactive daughter, which in turn decays to a third radioactive material, which decays to a fourth, a fifth, and a sixth. Each of those isotopes need to be considered in terms of the dosimetry to understand the total effect. Eventually, the decay chain ends with a stable element. A recent publication by the International Commission on Radiological Protection, or what we call ICRP, lists other practical purposes and justifications for calculating dose at a clinical site and for completely characterizing the energy imparted to normal organs and tissues. And just to review why dosimetry is important in other contexts, it's part of evaluating the drug product safety and efficacy. It's used to prepare the package insert. It's important for treatment planning for radionuclide therapy. Dosimetry provides essential information for medical follow-up, discussion with radiation safety committees and with patients. Dosimetry is important for ensuring complete patient medical records, for demonstrating regulatory compliance with dose limits, and perhaps for fulfilling other legal obligations. And then lastly, I think it's important for protecting the medical institution in the event of unwarranted litigation. When we look at dose to the arm, we need to consider two different targets. First of all, the dermal tissue, the subdermal fascia, the vasculature, the connective tissues, the nerve fibers, and lymphatics of the arm. We call this the infiltrated tissue, or that part of the arm that receives the radioactivity. For regulatory purposes, there's a second target tissue, which would be the proximate or adjacent basal cell layer of the overlying epidermis. Looking at the...
Can you answer a couple questions about that basal layer for me? So we had talked kind of about how the layers of the skin, so how the first layer of your skin is dead, and then you move to that basal layer, and it's kind of, we had talked about sunburn. Can you give us kind of a brief explanation of how superficial the basal cells are?
Sure. The epidermis, or the corneum of the skin, is dead tissue. The epidermis is populated by cells born in the basal cell layer, as you see the layer of red cells surrounding the hair follicle. And then there's a subepidermis fascia, which we call the dermis, and it overlies an area of subcutaneous fat and muscle. And the infiltrated region can be represented here by this blue space.
So of the two targets, of the dermal tissue and the basal cell.
Yeah, they're two different targets.
Okay, so which one occurs most frequently?
No, they both occur simultaneously.
Okay.
But in terms of calculating radiation dose, we need to consider them separately, because the regulatory authority, either in the state or at the federal level, has separate limits for each of these. And we assess the severity of the dose in terms of either skin dose or tissue dose. So they're both targets. And the geometry of the infiltration can help us determine the dose to the basal cell layer, as well as the subepidermis, dermis, and fascia, as represented in this cartoon. I'll go back one slide here. There was a recently published paper in the journal Health Physics describing the practical methods for calculating radiation dose to these two different tissues. Remember that the federal regulations address arm tissue separately from skin dose. Skin dose is typically calculated only for external contamination, such as at a nuclear power plant. But if we use the same software, for example, VARSkin, we can reverse the position of the activity and calculate dose to the sensitive basal cell layer. That dose is calculated for a reference area of 10 centimeters squared as a circular area. To calculate dose to the infiltrated tissue, we can use the common Merz schema, and combined with Monte Carlo to calculate that dose.
So before this, was there a method to measure dose before this article came out?
Yeah, both of these two methods exist already, but they haven't typically been applied because, first of all, there isn't sufficient knowledge in the community to do this. And secondly, the tools may not be available, or there may not be sufficient expertise to calculate dose. And that's
Okay.
why we think it's important. And the MERT committee of the Society of Nuclear Medicine will be doing further work in this area to promulgate methods for the broader medical community.
But this article did give some methods on how to measure that dose, correct?
Yes, we provide these methods and explain how
Okay.
dose can be calculated.
Okay.
So the paper by Osborne et al. This year highlighted several important findings. And these were, for example, that extravasations occur much more frequently than appreciated by many clinicians. Secondly, the diagnostic radiopharmaceuticals, those based on technetium-99m or fluorine-18, can also impart substantial radiation doses to tissue in the event of these cases. In the 26 cases that we studied, we found that the infiltrated tissue absorbed dose ranged from 0.6 to 11.2 gray. That might be compared to the typical limit expressed in the regulations of 0.5. The shallow dose equivalent to the basal cell layer approached or exceeded dose limits established for occupational workers, and higher doses result from radionuclide therapy events, and there were quite a few mentioned in the published literature.
Okay. Can you tell us why you chose the technetium and the fluoride dioxide glucose to study? We had talked about how there's different types and different products, and you had a really great explanation behind why you chose those specific radiopharmaceuticals.
Well, technetium-99m is common to about 80% of all nuclear medicine exams. Fluorine-18 is up and coming as a most popular method for looking at both anatomy and functionality.
Okay.
Particularly important in cardiac studies and brain studies and other investigations.
All right,
So
thank you.
these are important, and the doses can be rather substantial if the activity is confined to a small tissue volume. For example, just for the physicists among us, 13.2 millicuries and 5 grams of arm tissue with a half time of 42 minutes, which is typical, imparts an absorbed dose of 1 gray, or double the limit. The total number of decays at the site by the atoms present, about 1.76 trillion. Each decay imparts locally about 13% of the total energy released from technetium-99m. The other 87% not imparted comprises energy in the form of the photons that are imaged. But the 13% that can remain in the arm can contribute substantial dose. I'd like to conclude by saying that I'm a true believer in the medical benefits of nuclear medicine procedures. The benefits are great relative to the potential risks. Even though extravasations may be relatively infrequent in the clinic, that event characterization and patient-specific dose assessment are useful for helping physicians evaluate the severity to better understand whether patients should or should not be followed for adverse tissue reactions. And the Medical Internal Radiation Dose Committee of the Society of Nuclear Medicine will be developing further guidelines for this community for calculating doses for extravasation events.
Thank you so much, Dr. Fisher. And I would highly encourage anyone to reach out and ask questions. Like I said, I've gotten to know these panelists a little bit. Dr. Fisher was extremely patient and kind with me when I called and we went over his presentation. I happened to be in an airport when we did that, and I got off the call and the guy next to me looked at me, he's like, "You're really smart." And I'm like, "Not as smart as the guy I was on the phone with." So I would highly encourage anyone, all of these panelists have been extremely gracious with me answering questions. So trust me when I say you are welcome to ask anything of them within their scope of practice and subject matter, because they were very gracious and kind with me. I'm gonna let Dr. Fisher hop off, and thank you so much for your knowledge base. Ted, do you want to bring up the last polling results quick? We can just run through those. So when we talked about that, 56% answered the gamma emissions leave the body and other energies. So just to give you an idea of that. And then we're going to bring up our fourth polling question here. We're going to run through this real quick here, and we'll let Dr. Fisher hop off, and we can ask our question here. So if an extravasation or filtration of a radiopharmaceutical caused adverse tissue reactions, when would these symptoms likely present? So do you think they would be immediate? Would they be within 3 to 24 hours, days to weeks, days, weeks, or even years? Or possibly you don't know the answer to the question. That's fine, because we love having you here today to learn more about this. So I'll let you pop in on that question. I will go ahead and introduce our next speaker. Dr. Amarjam Borum is a radiation biologist with a research expertise in normal tissue radiation injuries. So she studies the normal tissue dose in radiation injuries. She's on the faculty at the University of Arkansas for Medical Sciences and is currently the director of the UAMS Division of Radiation Health. So Ted will go ahead and close that poll, and we'll give you an idea. So we kind of have a split margin here between that short 3 to 24, days to weeks, or again, that subject matter we're going to learn more about. So we'll go ahead and pop over to our next subject, our panelist here, and we'll let her go ahead and get her presentation up and going. And did I say your name correctly? I worked really hard on it last night.
Very close.
I will take close.
Burma is my last name. So let's see.
Okay, so we can see your slides. If you want to put them in presentation mode, yep, it looks great. You can go ahead and start your presentation.
Perfect. Thanks so much, Mary.
Absolutely.
So I was asked today to give you a very brief perspective from a radiation biologist standpoint on what we know about radiation injuries to tissue. And of course, there are a few examples out there, as you can see here on the screen, of what may happen after high dose extravasation. So I will talk about those a little bit, and also the reasons why we don't know so much about lower dose extravasations and the normal tissue effects of those. So first off, to put everything in perspective, you already heard from Dr. Fisher on radiation doses. An absorbed dose that we often indicate in gray. Now we do that because when tissue is exposed to radiation, to ionizing radiation, what the radiation does is it actually transfers some or all of its energy into the tissue. And so when it does that, what we can indicate, what we can measure is the amount of absorbed radiation dose in joules energy per kilogram tissue that is exposed. And that becomes then 1 gray. Now the gray is the international unit, and as you may know, us Americans, we sometimes like to do things different. So you may also see absorbed doses indicated in red, and here in the United States in particular, but it's quite easy. 1 gray is just the same thing as 100 red. And what I wanted to do is give you just a little bit an idea about numbers of exposures of absorbed doses. So here in the middle, you see in a regular PET SPECT procedure, the dose to the whole patient, it would be in about 1 to 2 milligray, so only 1 to 2 thousandths of a gray, very low. A CT scan can be quite a bit higher already, at least 10-fold higher. But these doses here in the milligray, in general, we consider them relatively safe. However, there are also types of radiation exposure where the radiation dose gets much higher. So for instance, in radiation therapy, often done in the form of X-rays, the local dose to the tumor and to some normal non-cancer tissue that is around the tumor would be 2 gray per day. And these patients often get treated with several fractions over, for instance, 30 days of 2 gray each day. And especially when we come to these higher absorbed doses, such in these cancer patients, then we know that negative effects can occur. Now, why do we call this ionizing radiation? So the radiations that you have seen, the examples that you've seen today, they're all examples of ionizing radiation. But ionizing radiation is actually a subset of a large number of different types. So ionizing radiation can be electromagnetic waves, but they can also be charged particles. And each of those, they have one thing in common, and that is that they can ionize the atoms and the molecules in the tissue that they expose. And what happens is they basically have so much energy that they can knock electrons out of the atoms of the tissue that is exposed. Now you can imagine that that will cause molecular damage. So that's illustrated in this diagram here. So the ionization or the knocking out of the electron can occur directly in macromolecules in the tissue, such as our DNA. But because our cells and tissues mainly consist of water, actually, the ionization often happens in the water molecules in our tissue. And this causes ions to form and also sometimes free radicals. These are all, most of them are highly reactive, and they will react again with molecules in their surrounding. So they can then indirectly react with, let's say, DNA and cause more damage. Now, fortunately, our cells, right after that molecular damage has occurred, so that occurs almost instantly after exposure to ionizing radiation, our cells have very sophisticated machinery available to detect that damage and to start the repair of the damage. And so most of the cell repair of this damage will occur within the first few hours after exposure to radiation. Most of that cell repair is done within the first 24 hours. And often, fortunately, that cell repair is very successful. And in that case, when we look inside the tissue, we can actually really see no trace at all of prior radiation exposure. However, the cell damage, the cell repair also sometimes fails, and this could lead to, for instance, mutations. And this is why ionizing radiation is actually quite known for being a carcinogen. So if these mutations remain in the tissue, in time they can develop into tumors in the tissue. But this often takes years to occur. And so, for instance, in the skin, what we are concerned about is these mutations happening in those basal cells that Dr. Fisher talked about. Now, when repair fails, or if there is a lot of initial damage, then we can also see cell death occurring. And you can imagine that if there is a lot of cell death all at once, that this could lead to a loss of function of the organ or the tissue. So this could lead to adverse tissue reactions that are actually quite different from the carcinogenesis. And the last few of my slides will focus on these other adverse tissue reactions. Now, these tissue reactions, if they are mostly due to this cell death, they will occur within days after radiation. That makes sense. However, those adverse tissue reactions are way more complex. And so there are several mechanisms, biological mechanisms in our cells and tissues that will progress right from the first molecular tissue damage, and they will actually cause or contribute to those adverse tissue reactions. And here you just see a few examples. Vascular damage can occur and can contribute, and inflammation, for instance. Many of those mechanisms we still do not even fully understand. And another complication is that they may take years sometimes to progress and develop. So it's possible that some of these adverse tissue reactions actually only show up years after radiation exposure.
Dr. Wilmer, you are about at that 7-minute mark, so you have about 3 minutes left with us in the audience.
Perfect, thank you.
You're very welcome.
So what kind of tissue effects can we expect from extravasations? And we know this from the few reports that are out there on high dose extravasations. Here you see another example, but most of these effects we actually know from external radiation exposure, such as in cancer patients who receive radiation therapy. And so what we maybe expect is a reddening of the skin, peeling of the skin, again, damage to the vasculature and inflammation, or also excessive scarring. Now we know that this can happen after high dose exposures. From lower dose exposures, we just really do not yet understand fully what may happen. And that is in part because there are very few reports out there where we actually document lower radiation dose exposures to patients and follow them up long term. And so that is what I would also like to highlight in my last slide here with some summary of this talk. So first off, after at least a certain dose exposure, we can expect adverse tissue effects localized to the extravasated area, because that's where this ionizing radiation actually transfers its energy into the tissue and causes damage. Long-term tissue effects of these extravasations are largely unknown, and that is in part because there's at this point no systematic determination of absorbed dose after administration of the radionuclides. There's no long-term follow-up of patients typically, and there's really no system in place where we all are consistent about reporting those findings. And although being able to report those findings and review those reports would help us as radiation biologists very much in understanding much better what will happen after low dose radiation exposures. Now, of course, as is the case for all other exposures, scenarios of exposures to radiation, we need to continue to try to minimize extravasations of radiopharmaceuticals. And then lastly, what we in the field of radiation biology are also working on are treatments that we may use to mitigate tissue injury after somebody has been exposed to radiation, either due to an extravasation or due to, for instance, external radiation exposure in cancer therapy. And so with that, Mary, I would like to finish, and I really look forward to our discussion later on.
I do as well. Thank you so much for your information. And when we had spoke earlier, you just do a really nice job with making the information tangible. And so thank you so much for sharing with us today. I'll go ahead and I'll let our last presenters, Nancy Warden and Stephen Harris, go ahead and bring up their mics. We're going to have one last poll question. So as a participant, you have a questions box. That's where you can sure type in any questions you may have. Maybe if you want to address a little bit about yourself or your background, we would welcome anything about yourself along with your question. Ted, I'm gonna let you bring up that last polling question so we can give an introduction to our subject matter here. So the polling question states, how often are ultrasound or other vein finding technology typically used in gaining venous access for nuke med imaging procedures? So this would be an idea of how often is that ultrasound used. So rarely, less than 5% of the time, 5 to 10% of the time, 10 to 20, 20 to 40, or possibly 40 or more % of the time is ultrasound being used to find that vein technology. We'll go ahead and leave this up during my introduction of our next panelist. So next, we're going to welcome vascular access expert Nancy Warden. She has over 20 years of nursing experience and also nurse leadership. She's a board certified nurse with a bachelor's degree in nursing and master's in business and healthcare management. And she will be, her co-presenter is Stephen Harris, is also a registered nurse with a career focused on vascular access. He's highly skilled at both placement and instruction in insertion of multiple vascular access devices, including ultrasound guided peripheral IVs. So we'll go ahead and finish our poll up here. Ted, we can go ahead and end that. We'll see our results for this. So 73% said rarely, less than 5% of the time. So I think this is a great segue. I'll go ahead and skip to myself and the presenters, Ted. I think this is a really great segue for us to welcome our next two panelists in order to give us more information about this topic. So I will let you go ahead and start your presentation. It looks good on our end.
Okay, thank you so much for having us today. We are very excited to be here. Steve and I have been in the field of vascular access for a very long time, and we know for certain that this happens, extravasation happens, and we have been waiting years for a forum like this to take place and really dig down to why this happens and what we can do to mitigate and prevent it from happening. Okay, as part of our research, we wanted to know, we are not radiology nurses. We do not actively have a role in the radiation department, nuclear medicine on a daily basis. So we wanted to know when we started this process, what is happening in a lot of our large teaching hospitals. So we asked the questions, do you have a strong vascular access policy and procedure? Out of 8 large teaching hospitals in North Carolina, Virginia, and South Carolina, no one had a strong policy and procedure in place. No annual competency assessment and intervention if needed. So common verbiage, nuclear medicine staff will be checked off by senior nuclear medicine staff member at hire. So the approach often was see one, do one, teach one, meaning there's no policy. You come in, you're hired, you do a few IVs with your preceptor, and then you're signed off, and you can also start to train folks how to do it. Regretfully, preceptors found it challenging to accurately identify the correct steps in safe vascular access. We actually asked some questions to the strong preceptors in each of these groups, and the practice variations were astounding. So that got our attention. And finally, staff poll included physicians, nurses, nuclear medicine technologists, and various radiology team members. Our experience with radiopharmacological administration. Latest access technology or best access methods are not being used. And this speaks to what our previous presenters touched on. There are assistive devices out there that could help aid with vascular access, but in our experience, departments are not using them. They don't even have them in their department. And another thing that jumped out at us, immediate mitigation steps for extravasations are not known. So no one could tell us what to do if it happens.
So a lot of this, relates to I find this amazing that 25 years ago when I was a new nurse and I had a little conflict with policy, an old doctor said to me, as long as you're on the side of patient safety, you'll be on the right side. And I think as we go through this, that's like kind of the approach that I'm using. And, we see this is a flyer put out by the Society of Nuclear Medicine and SNMMI, and they talk about, this is a patient flyer, and it says that they're trained in that nuclear med techs are trained in venipuncture. And I'm sure there are programs that have excellent training, but in our experience, we've had a lot of what we see in other fields with vascular access is that people are taught by a senior member. They may or may not have didactic training. And when I know I used to work in radiology and would assist with IVs for very difficult patients, the focus with the dosaging was often very specific to that site, that arm, and that dose, without taking like the big picture into account. One time specifically, I looked under a patient's gown and there was a large extravasation that had nothing to do with nuke med, but the nuke med tech was attempting in the forearm below the extravasation site. So I think that through all of this, the training is really important. competency, what to look for, and understand that when you're injecting anything into anybody, it's not a small picture scenario, it's a big picture scenario. Unfortunately, today in hospitals, we see a lot of medications running KVO, and a lot of my personal experience with nuke med techs is if they see KVO, they do a flush test with or without checking for blood return. Blood return is not a sure way to ensure a good injection, but it is helpful. And so this getting back to this little flyer, I just think it needs to be, when we're communicating to patients, we have to be more direct, both in what the nuke meds responsibilities are, like they have to have their policies in place, and they have to, their training has to be like any nurses. You know, there's many states right now that require hours of clinical training. You know, I looked it up, that it was ranging from 12 to 60 hours of training before you start an IV. And again, with the poll we did, we heard again and again, well, I got signed off by a senior nuke med tech. Well, how much theory did you get? You know, very little theory classes.
Can I just jump in here and ask one point of clarification? When
Sure.
you say KVO, what can you tell me what that stands for?
KVO is keep vein open. It's a slow
Okay.
infusion, sometimes 20 to 40 milliliters an hour.
Okay.
And the issue with many, you know, as obesity increases, especially in this country, you can have a KVO rate running for hours before anybody will notice infiltration of that saline. So
Okay.
without blood return, you know, and I've even felt the arm while I'm flushing, and it's very difficult to determine whether that's a clean flush or where the tissue is going. You know, there's a difference between a 110-pound person and a 400-pound person on where that flush is going.
Yeah, thank you. I'm a CT tech, and so traditionally our access points are short term. So, and then I just do want to let you know you're at about halfway mark. You're about 5 out of the 10 minutes. So I really appreciate your, you know, when they do happen. So we have a little bit of tools and resources. So just to give you an idea of time frame there.
Sure. And then, you know, we're seeing in the cases we've seen in this, it talks about icing. And, you know, the great majority of extravasations are iced, but there are certainly in chemotherapy certain agents that you do not want to ice, and certainly with, you know, isotopes, there are situations where you do not want to ice, where you actually want to put a warm pack on. A lot of times we feel that these should be evaluated by plastic or vascular surgery, because if the patient doesn't know, what do we know, right? And so we've had some instances where we've seen something's happen right away, and from the other presenters, you can tell that there's instances where things are happening 3 months down the road, 4 months down the road. So this reporting, to me as a nurse, is concerning, not just for the quality of the study, but for the localized effects at the injection site. So it seems that, you know, I'm learning a lot as we go through this presentation, and based on the way these isotopes affect people, some of these people need to be followed for a long time. And if that's not being reported, that kind of fits into a big of patient safety. What are we doing? Are we doing our due diligence on from the training of the injection and the IV to the follow-up?
The next steps we're going to talk about is prevention, major steps. A good vascular access policy and procedure, those steps are critical. We got to start there and have a core in our departments of a good P&P. Peripheral skills education is vital for technologists. As Stephen said, nurses across the country are mandated every year to do a certain number of hours of vascular access training and return demonstration and have a competency on file. So that would be a good step for technologists as well. Skills must be validated by a trained vascular access expert. Someone that knows vascular access, not the see one, do one, teach one. Because if you're just validating each other in your own department, you could be validating bad habits that you don't want in your policy. And again, annual competency and check off of skills, documented live proctored venipunctures, someone coming in and watching what you're doing. This is all key. Peripheral access skills. We should be asking everyone that puts a IV needle, catheter, any needle of any kind into someone's body, what is the basic anatomy of the vascular system? Why is vein preservation important? Stay away from the antecubital space in the back of the hand. The antecubital space is the go-to for technologists. We found that in our poll because usually it's pretty big vein, it's easy, but I don't know very many patients that when you put it in that area of flexion, when you put that catheter there, that they're going to hold their arm stock still while you go get your radiopharmaceutical, come back, inject it. They could bend their arm, they forget, and when you inject, you could be injecting into a catheter that has come out of the vessel for some reason.
Nancy, I'm going to ask
Basic
you
infusion
really
principles.
great case studies at the end of this. I said, I'm going to ask you to just move on. You have some really great case studies at the end of this presentation, and we are out of time for this slot. But I do want to at least allow those case studies to be shown because they're really interesting. So, if you want to share those with us briefly?
Yes. So our first patient was a 29-year-old male being treated for non-Hodgkin's lymphoma. He presented to the Nuke Med suite with a 24 gauge in situ in his right forearm. Patient complained of burning when the agent was given and when it was flushed. Patient was being treated with Zevalin and discharged day 2. Day 27, patient was at home and contacted his oncologist for pain in a black spot where the IV needle was. That was a direct quote from the patient. Patient presented to the oncology office. The oncologist didn't know what to do for him, so sent him back to the emergency room at the hospital where he had the test. The ER physician contacted the Nuke Med department and was told to have the patient use ice and elevation until the symptoms subsided. Upon medical record review, the technologists documented, that the PIV in the forearm was received from the floor, and that it was good and used. When the patient presented the IV, it was also noted that the IV did not have blood return. So instead of a further investigation, the technologist went ahead and used the access that the patient came with from the floor. This was a radiotherapeutic study. You can see here where the IV was in the patient's arm. The patient was discharged from the ER with instructions to ice the arm until symptoms subsided. The patient sought care of a plastic surgeon who chose to watch the site closely and take a wait and see approach. When we drilled down on this case for this patient, the first thing that jumped out on us at us was a 24 gauge catheter was used, 1/2 inch long. That is too small for an adult patient. So when the patient complained of burning, a good thing for the tech would have been to, when in doubt, get it out, restart a new access, especially since it did not have blood return. Often these short PIV catheters are used with the mindset of, oh, it's a small catheter, it doesn't hurt as bad, it's good enough for this short-term use. And we all understand that, but what happens, there's not enough catheter seated in the vessel on the adult patient, so it pops the catheter out of the vessel so the patient gets an insertion site full of whatever that is being injected. And again,
I do want to have, Nancy, I'm sorry to interrupt you again. I apologize. I want to make sure we have time to address a few questions from the audience. Do you want to go ahead and I think a picture is worth 1,000 words. Can you go ahead and flip those slides and give us an idea of some other effects that have happened?
Yep, we're good to our next case study.
Okay.
This was interesting because this was a patient, and I know we're short on time, so I'll kind of go through quickly, that had a functioning midline in and got a separate 18 gauge IV in a separate arm right near the midline. And the question would come up was why couldn't the midline be used? And there was some policy questions. And 1 week post the isotope administration, the vascular access team was called to look at the midline. This site had been bothering the patient since the injection happened, and they were icing it. And so what ended up happening is that we got a venous Doppler, and it showed to be clear, the IV was in the cephalic vein, the midline was in the basilic vein. The venous Doppler revealed significant thrombolytic changes with the cephalic vein just above the antecubital space. Also of note, you'll see, we ended up pulling the midline to try and free up blood flow because we thought, based on our ultrasound, there was some congestion there. But you'll also see on this picture, I guess we'll bring this up, that the IV was hubbed. You can see that prominent hole in the skin, and you have a lot of people in vascular access that think that they should push a device in as far as you can. So this was a pretty severe extravasation. You can still see the dressing from the midline on the underside where the basilic vein is, and then the top injection of the cephalic vein. So, this was obviously disturbing to us. And then unfortunately for follow-up, this patient did pass away of other causes in about 6 weeks after this occurred. So it just is a strong example of what can happen. And my first question was, wouldn't have this whole thing been easier if we just used the midline for the infusion? Because the midline happened to have excellent blood return.
We understand that that's not best practice at this time because we're unsure of how well that midline device can be flushed. So that said, we understand why the 18 gauge IV was started. And again, we happened upon this because we were called to assess the midline that we had started a week prior before the test. So
I'm going to go ahead and kind of cut you off. I apologize. I'm so sorry. This information is absolutely vital to us, but I do want to have time just to take a couple questions. So I think it's great that that we are cautious and we're conscious of this vascular access, but I'm going to go ahead and thank you so much for your time, and I'm going to move on to a couple of the questions that we have. Thank you so much. And like I said, I apologize for not giving as much time as allotted, but that was our time for today. So thank you so much for being with us, and I'm so glad that you've finally got to take the time to present this information. So thank you so much. Yeah. So I'm going to go ahead and move to the questions here. So
it looks like we may have lost Mary. Nancy, are you seeing that as well?
I don't see Mary. No, I do not.
Okay. In that case, I'm gonna go ahead and jump in here and go through some of the questions we got. If everybody could bring up their webcam so we can get sort of the full panel together, that would be perfect. And then Nancy, if you're able to stop screen sharing, that way everybody will just see all the faces from the panel, that would be perfect. Otherwise, I may be able to. Perfect. So Mary may be able to rejoin here, and in that case, I'll let her take over again. But otherwise, I'll move through some of these questions we have. So the first one we have here is, this one was asked during Dr. Kaiser's presentation, but if anybody else on the panel has expertise here, I think we're happy to hear from them as well. So what do you feel is a prudent volume of saline to run into a patient intravenously prior to administering the radiopharmaceutical? I'm particularly interested with regard to the automated PET injecting system, not really the CT rapid infusers.
Okay, so when we start IVs, and we typically, since we know they're short term, and this is more actually a technologist question than a radiologist question, but they'll start an IV short term, make sure there's blood return, and then they'll do usually like a 10 cc flush. And when we're using the Intigo device, which is the PET injection device, it usually flushes very slowly with about 50 cc volume, and it does it quite slowly, as I said. And one of the things that we've actually studied is what happens if we start doing our hand injections, because sometimes we get unit doses, we don't have bulk. And when we have unit doses, we have to inject by hand. So we'll inject that and then do a very slow push, trying to mimic the Intigo device so that we have like a better delivery of the tracer. So with that small volume that we typically get for PET and nuclear medicine radioisotopes of like 2 cc's or less, it's nice just to have that good flush, a slow flush, to make sure it's kind of distending the vein and allowing a good flow into the systemic circulation.
All right, thank you very much for that detailed answer. And I'm going to keep moving through these questions. I see we're right at our time. For our panelists, if you are able to stay on for just a few minutes, I'll get through these questions. And then for any attendees that have to jump off, we will have a recording of this available after the fact, so you can catch some of these questions. So I'll try and move through this quickly. The next question we had is, we currently track CT and MRI contrast extravasations per CMS. Is there any mechanism for radioisotope extravasation tracking? This is from Kevin Botello.
I mean, I can take a stab at that, but I don't know if the physicists want to weigh in first. What we have begun doing here, we actually use a device that monitors our injections to make sure they're adequate. But when they are inadequate and we see a large infiltration, we will have that analyzed. And there are some algorithms that have been developed by the physicists and engineers that can actually calculate the small volume dose to the tissues. And when we feel like there's a large dose, we kind of use 2.5 gray as our cutoff, which is pretty significant. If we have a dose higher than that, we actually report these to our radiation safety committee. It's not required. Unfortunately, it doesn't happen very often, but since we've begun this program back in, I'd say, last August or July, we've had maybe 4 or 5 events like that where we've had very high tissue extravasations. So that's kind of the way we handle it. We're not required to do it, but we're trying to get ahead of the game with that.
Got it. Does anybody else want to chime in? Otherwise, I'll move on to the next question we've got. All right, looks like Mary is back here, so I can hand over the questions back to you, Mary. So we just got through the first couple of questions. So the next one we have is extravasations that occur with other venous access procedures. Are they considered reportable events, either internal or to agencies? So anybody who wants to chime in on that one, I'd love to hear the answer.
I'll take that if you don't mind.
That sounds great.
According to current policy, the Nuclear Regulatory Commission, the states do not require formal reporting of extravasation events. This policy has a 40 or so year history.
Wow. Okay. So I think that
Regardless of the dose.
I got it. So I think that's a very interesting thing to learn, especially given all that we've heard today. Mary, are you okay to jump in with the questions, or do you want me to just keep running through them? All right, I'll jump forward with the next question here. So here we have someone, James Greiner says, I have injected via IV in the absence of blood return, but only after 1 bolus 10 milliliter of saline, and noting the patient reaction and appearance at the injection site. Is this not sufficient precaution? I think you may be muted on Nancy's screen. If you could unmute quick, I'm sorry about that.
I think I should be back, Ted. Thank you for taking over for me. Somehow of course, the only time internet ever stops is right now. So thank you for taking over, Ted. I apologize. Thank you for helping.
No problem.
In regards to that question, and when we look at other aspects of infusion therapy, we have specific rules and standards about, like, for instance, therapy, you would never use an old IV that was already present. It has to be a new IV, avoiding an area of flexion with established blood return before you administer that dose of chemo. So there are specific rules and standards of practices from an infusion therapy nursing perspective, if that answers the question. I personally, if I was going to inject something that I knew had the potential for this type of patient harm, the absence of blood return would make me get a new IV. I would not want to inject without blood return. Although that's not a fail-safe, it's a really good indicator that your catheter's in the right place. There's been, with one of the main things with IV lawsuits, unfortunately, a lot of attorneys advertise that in their yellow pages is, you'll see that absence of blood return, yet device was used anyway. So And certainly in a central line, that's a required thing for use of a central line.
That's good. I'm going to go ahead for, out of respect of everyone's time, we are about 5 minutes over. Possibly vascular access would be a great thing to continue to discuss. Does anyone have any final comments or anything they want to share before this webinar will be available after the program? So if you have other questions or things, you can still reach out and we're still happy to address any of those. Does anyone have any final comments before we go? Otherwise, I would like to thank all of you. Like I said, you have been gracious in your knowledge, faith, and just really to create awareness of this topic, I think is something we accomplished today. And I feel that was a main objective as I talked to all of you this week. So I really appreciate all your time and effort on your presentations and preparing your notes and presentations and really sharing that subject matter with us. So thank you so much for your time. We appreciate it greatly, and I'm really excited that we're able to create some awareness today. So we are going to go ahead and log off. If you have further questions or comments to speakers, again, you're sure willing to submit those. So thank you, everyone, for taking the time to be with us this afternoon. We really appreciate it.